All right. Thank you, everyone. Good afternoon. So I'm really excited to welcome you back to our last session, which is, I think a really important way for us to end begin to bring our symposia to a close, which is around setting priorities for navigation for health equity. And I'm really pleased to welcome my colleagues, Dr. Jennifer Sway and Dr. Narissa Nanzi, to the podium. And I'll just say a few words about both of them. So Dr. Sway is the inaugural director for Cancer Care Delivery Research and Implementation Science at Norris, and is also on the faculty in the Department of Population and Public Health Sciences. And in her role as the Director for Cancer Care Delivery Research and Implementation Science, she's responsible for fostering research that improves patient, clinician, and organizational factors that influence cancer care delivery. And along those lines, really works to enhance uptake of evidence-based practices and research. And Dr. Narissa Nanzi is a health services researcher and assistant professor in the Division of Health Equities within the Department of Population Sciences at City of Hope. And her work focuses on disparities in cancer care and outcomes in underserved populations, and particularly in safety net settings. So we really kind of designed this panel, this discussion, to be sort of a bookend to our previous discussions about navigation in a safety net healthcare system, patient and community and population level navigation, industry, industry and policy panel. So this is really where we're gonna, the magic will come into fruition, so.
Magic. Yes. Norris and I have known each other for a long time, so we love the opportunity to be sort of standing together from different institutions now to join forces and sort of close us out as a dynamic duo. I hope we're not overselling before we actually do it, so we're gonna try to get it done. Do you want to set us up with?
Sure, yes, and I think also just want to pay respects to the origin of patient navigation, started in the 1990s by Dr. Harold Freeman after noticing the breast cancer disparities in Harlem, New York, and how far we have come. We're here 35 years later, giving light to this very important topic still, and that only demonstrates, the progress that has been made within the clinical and community setting. So thank you so much. Do we have
So what we're going to do, right, is start first by hopefully summarizing all the cross-cutting themes that came across our three amazing panels today. I know there were so many great speakers, very important points, and perspectives from sort of all across existing partners that need to be at the table here, right? So hopefully we can do this quickly so we can get some words on those sheets over there. So the first theme, and I think undeniably, there are complex social determinants facing our communities. We cannot address anything without incorporating, acknowledging, and building the social determinants of health into our strategies for navigation, right? Social determinants is a huge beast.
According to Dr. Lee.
It includes food insecurity, insurance, violence, medical deserts, racism, big R and little r, childcare, transportation. And what we talked about this morning was meeting people where they are, right? Getting priorities that are based on communities and not set by the systems and the care delivery settings, but rather voiced by the communities themselves. Leveraging non-traditional resources and settings to engage and address social determinants of health, and recognizing the intersection of environments, systems, and societies from our last panel, right? It's not just the systems and the engagement with the community, it's also our changing environment and our ecoclimates in the smaller context. And then lastly, upstream investments, covered California and other programs. How are we going to look at upstream impacts that now affect patient access to trials and treatments and needed care? So the second piece is stakeholder engagement. I would say I love this meeting every year because we're all here as stakeholders, right? I think there's so much intersection here between clinicians and researchers, community advocates, the people who do the work on the ground, industry and payers, hopefully, who can be joining us soon. But here today, this morning, we talked about building, representing, and sharing community voice. I think that was front and center in the morning sessions, community voice as a central tenet of where we need to go with navigation. This includes collecting data, listening to Black Californians through the statewide survey, covered California enrollee surveys, public comments, and then I think this point about building trust in healthcare. So many of us who focus on health equity know we need to not only acknowledge that there's medical mistrust, we need to build trust, we need to find trusted messengers, we need to leverage the knowledge within the community. I think through promotoras and other community health worker programs, how do we leverage the trust between community members to then be able to move people into the healthcare space when they need care, when they seek care. So those are the two main things from this point.
And then also another cross-cutting theme was about, tested patient navigation models. We saw a lot of, patient-centered models, a beautiful example from LA General this morning about clinical integration across the cancer care continuum, other population-based models, including anywhere from community-based education to actual outreach and enrollment for health services or to coverage. And, the approach that Covered California took with population health investments, food security, practice transformation as just some examples. We saw different types of clinical backgrounds. You could be from a social work background as an LA General or non-clinical backgrounds as well. And then different parts of the cancer care continuum. We saw some earlier on in the continuum, out in the community, and then also navigating through treatment. Another recurrent theme was this data-driven care. You saw many presentations showing output from their quality improvement initiatives and really backing initiatives with the data, seeing those large increases, for example, in cancer screening within LA General, or some of the other data that was presented within our last panel. And then finally, policy is a powerful lever to improve health equity. Again, it comes back to that recurrent theme about coalition building. We're all kind of doing separate things, funded by separate initiatives. How can we build coalition and capacity and integrate the work that we do? And we also heard about other legislative initiatives, for example, with the California Cancer Health Equity Act, the California Black Health Network helped to propagate as well, and other forms of policy like community health worker policy and reimbursement, for example, for navigation services. So these are all levers, that can inform how navigation is implemented on the ground.
So with that, I think we're going to move into what we should cover over priorities. Right? Is this? And before we do that, if any of you have comments on pieces we've missed, we were listening intently, typing quickly, trying to be succinct, but let us know if we missed any of the cross-cutting themes from the morning or any important points.
And we think this is an opportunity, yes, to turn up the heat.
We need to turn up the heat, right? So that's where we're at. We're landing at setting priorities at the end of the day. So setting priorities in terms of these three buckets is what Norris and I sort of talked about where our vision can go, right? The first in models of navigation. How do we move towards a population health delivery setting scale for navigation? How do we prioritize populations? Who are our priorities? How do we decide that? How do we identify them? And then how do we reach them, right? It's the entire continuum. Do sustainability.
Sure. Yes, and then also another piece of this is sustainability and scale up, and we've heard this throughout many panels today. We talked about the current landscape of health equity funding. Some of us are here to bring research dollars in and give it back to our communities as well. We're testing, models of reimbursement, whether it's through community health worker or the principal illness navigation that has now been approved for reimbursement of navigation services. And then also measuring and demonstrating value, impact, and building that business case for our healthcare delivery systems, right? We'd love your feedback on sort of the measurements for that.
And then really, how do we set priorities moving forward, right? It's not just in the short term, models of navigation, sustainability, and scale up, but long-term priorities. What do we see 5 years from now and then beyond 5 years from now, right? So successful implementation of policy. We talk about SB 987 here and elsewhere all the time. How do we evaluate that? How do we show outcomes so that we can make this a model for other states, right? For other settings. Coordination between primary care and across programs. I think it was Dr. Andy Lee who mentioned this morning. We don't want to catch them at the point of diagnoses or crises. We want to catch them when they're engaging with the system, and we want to coordinate navigation with primary care along the way. Norris mentioned this, but I think this is our vision and our dream, right? Building coalitions. We don't want to be doing the same thing at each of our cancer centers separately. We want to be doing these things collectively. We have overlapping communities we reach. We have multi-ethnic communities that we partner with that do different things with different cancer centers simultaneously on their end sometimes. How do we build coalitions so that we're efficiently optimizing all of this navigation care together? And then our last two questions, this is for the group, right? How do we be disruptors? Disruptors always seem negative, but I think we want to be positive disruptors. How do we do this quickly, better, faster, like industry in some ways, in some sense, right? And then lastly, how do we ensure that equity stays at the forefront despite our political climate right now? That is the fight we have to keep fighting always. So I think with that, missing anything else? Comments? Our goal is to finish talking so you can talk and they can write. That's our goal. So any comments about themes we may have missed, and we can maybe go back. Is there a back button on this? Yeah. If there are themes we've missed, happy to discuss some of that. If there are comments from the audience on priorities and prioritizing priorities, we can talk about that as well. Oh, no.
And we can have some more, for those of you who are internalizing your own patient navigation programs, some basic questions related to how you set your priorities for which patient populations you're targeting.
I was going to ask about the implementation for 987. You mentioned putting a lot of, thank you. Just putting some emphasis around that and working with other states too. How are you?
I think those of us who do health policy evaluation, thinking through what are the outcome measures we want to look at, right? The SB 987, I think, was enacted 2023. Oh, 2022. So it's been 3 years. Hopefully that means we can see some downstream impact here in California through data within health systems and in the community, and thinking through how can we use that as a case study for other policies in other areas?
Right. Yeah, and I was just going to say, if there's a way where industry or other partners can help support that or be engaged, we'd love to do that as well.
Great. Yeah, something to talk about more.
Comments related to your priority populations, or how are you able to select that within your navigation programs? Maybe I'll call upon Jess to talk a little bit more about the mobile unit.
She made eye contact with me.
How do you sort of prioritize your populations, and maybe what are some of the challenges that you've run into? And how does this make you rethink some of your models of patient navigation?
Okay. Hi, everyone. I'm Jess. So actually, I was just mentioning to Consuela about something that we struggle with, and that we haven't talked about, is the kind of dreaded word, prior authorizations. It leads to a lot of delays. And so I don't, just thinking about what are the obstacles, when we talk about follow-up and navigation, and what navigation, a lot of it deals with is following up with, like, how come that prior auth wasn't obtained? How long is it taking? And honestly, that's what leads to a lot of our very long delays. Choosing the population, I think, for those of you that don't know, we're a very new mobile program. We're officially a 1-year-old program, seeing our first patient, so very exciting. But I think our focus for this next year is finding the right focus. I think our focus for the first year was surviving, getting it up and running, making sure the wheels are still turning. And I think now that we've shown we can do it, now we want to do it the right way. And now we want to capture the right information, because I think for a little bit we wanted to do everything for everyone. And I don't think that was necessarily realistic. And I think you all definitely demonstrated that.
In his talks makes me think about, how we can use data and use a data-driven approach, and how we can work across our institutions. So one of the specific types of expertise that we have here at USC is in geospatial analyses. We're able to sort of identify cancer health disparities hotspots that could then sort of be shared with you and sort of help inform your outreach effort. And we can do that across different cancer sites. We could prioritize lung cancer, because that's one of the things that I think we're all institutionally very focused on. So I'm wondering about, what would be the best ways to share that information and share those insights, and how can we use this consortium to help facilitate that process? Do you mind? Like we sort of figure out how to share data across institutions, because it really just helps to improve the quality and impact of what we're all doing. And I think, as I mentioned, we have expertise. We have the mobile unit. We don't have a mobile unit. We'd like to partner and use your mobile unit.
I'm the person.
All right, good.
I mean, I think that's a great point also, even with the other cancer centers in the area, right? Thinking through, we each have our own health system data. We have our county level and regional data on cancer cases. We have our care delivery points. So thinking through how to assess this across the care continuum. And so many of us work with FQHCs, and maybe some of them are on Zoom today, but thinking through how to bring in our community providers and our FQHC partners, that's something we've been thinking about across the board, and particularly with our new Ralph Lauren Center for Cancer Prevention, sort of how to bring in our community clinics as an engaged partner in all our processes. They're the ones who see all of these cases first, right? The precancerous lesions, the initial abnormal screening tests. So along the continuum, great suggestion, Janita.
Yeah, and if I might just build on that, and some experiences and learnings from what we have done across the US, I think first and foremost, in order to be anything to be sustainable and to scale up, I think you really have to identify and prioritize either the disease area or the place where you really want to make an impact. More often than not, what we'll end up seeing fall through the cracks is when you spread yourself too thin and try and do too much without the ultimate focus of one thing. So, for example, I'll give you another one. We're working in University of Maryland with Tawfiq, Dr. Wanakoko, who's super passionate again on lung cancer. And his fundamental vision is to have fully connected data across the 11 hospitals under University of Maryland, to be able to identify which patients are being screened, which patients are being missed, social determinants, so on and so forth. And so it's so important to be able to, one, identify the disease area you want to work on, because then you can find out what data you want to actually look at. And that sets your baseline. And even with the California Coalition, the first thing we did was, what is the baseline screening rates in the UC system? Because what happens if you don't have baseline, whatever programs implementation you put in, you don't know whether it's going to work or not. So investment, I really think, investment in data and investment in getting some baseline understanding of your health system in specific disease areas are critically important. Then, of course, the program, which can then measure value. And lastly, I don't know I think it's a question back to you guys. I don't know what is stopping people from coming across the aisle in a way, right? Like, there's great stuff happening in the UC system, great stuff happening in Cedars, there's great stuff happening in USC. Now, what is the mode and mechanism you want to have to bring all of this together? And is there one project that you want to do all together, and what could that be? I mean, just a thought for you all to think about, maybe.
I mean, I want to answer, but I also don't want to answer. I would say there are many projects we've talked about collectively between UCLA, USC, City of Hope, Cedars. We grew up doing cancer prevention and control in this area, and we know these communities. And so every screening amenable cancer, for example, is one we've probably talked about before together, right? And so we can. I think one thing that we've opened our eyes to is who should we be talking to rather than across the aisle or between institutions, across stakeholder groups, payers, industry, right? Relying not just on federal funding, as we can see in this day and age, relying on federal funding will limit some of the disruptor type work we want to do, right? And so thinking outside of the box of that, I mean, I can go on forever, but I think we can, yeah.
I mean, if I may just, I think, yes, I mean, relying on federal funding sometimes can happen, and maybe.
It's great, yeah, it's great, yeah.
How do you create a self-sustainable funding model, right? Like, so I'm just using certain examples. IPNs for lung cancer, incidental pulmonary nodules, is a self-sustaining model for lots of institutions to institute an IPM program. Because an IPM program, eventually you catch people with nodules, they go into surgery, and then surgery, you know, it comes into the system. And so this becomes a self-sustaining program for most institutions to do. It requires a little bit of economic evaluation and showing back to them saying, hey, this is the value for you as an institution. So I think there's also something in that matter to say, how do you show it to your own institution that any program that you do can actually be self-sustained within the institution?
I just wanted to, Arun, I really appreciated your points. Tanima Berry here, I'm actually from Novartis, and we're working on some similar concepts on how do we do this in the breast cancer space. And I agree with you on not spreading too thin and you know, really creating some focus and the data-driven approach around, you know, identifying what the hotspots are and creating a baseline. My question is, to your second on outcomes, you know, when you had the baseline understanding, how did you set what the goal or target or the outcome was, and how did you kind of monitor to see if you're deploying the efforts in the right way to get to that?
Yeah. I'll be quick. It's like any other, you know, we got to set a goal that is achievable. Right? Sometimes people set goals which is not achievable and becomes demoralizing than anything else. So, you know, what kind of a goal that we need to come together as a team? So as part of the UC Lung Cancer Coalition, the coalition came together in the round table and said, what is really achievable in 18 months? What is achievable in 2 years? And held each other's hands to define that goal of 20% increase. Now, it might not be 20%, it might be 10, but at least you know that when you're collecting the relevant data and say, okay, what works? The other bit as well is, coming back to Dr. Hughes' point, is I think we are underutilizing the data that institutions already collect. So how do you able to mine that data to kind of show where do you want to put your efforts in, right? You might think that this is the area where you have social determinants of health issue, but unless you validate through data, it's hard for you to actually, you know, say that with certainty. So we mined data. And so we have a platform that shows exactly by county, by state, what are the social determinants and what are the factors driving poor outcomes within the care gap continuum. And so you're able to put the efforts right.
Great points. I think really important data, having the right data, collectively sort of utilizing our data in the most efficient ways. Perhaps in the last few minutes, we can bring back this conversation to focus on navigation a little bit. I know we started with navigation, and navigation sort of rolls into every other cancer we're interested in. But for navigation, what do we need, right? What can we do collectively in terms of the panels and the speakers today that we need to think about? Site-specific or not? Are there specific resources needed for navigation that we can think about over this next year between now and the next meeting we have?
Do we have FQHC reps here?
I don't think so. Just, yeah. They might be on the call.
I think thinking about navigation, we talked about this across teams and it came up a little bit today is, is the reimbursement model ready? Is that going to help us scale up the service? So to the audience or to you, thoughts on that?
Definitely to the audience first. Anyone have thoughts in the audience? Rhonda, yeah. We quoted you, Rhonda. So now
So I guess I wanted to clarify what you were, so are you thinking about when you say reimbursement model, who said that? Trista? So is this for insurance companies to yeah, so what I had been thinking about sitting here is, we are part of the Cancer Cares Different Coalition. We do policy work. So if there's anyone in the room who's interested in coming together to form a coalition to really advocate for, if community health workers can get reimbursed, navigators can too. So I think it would be beneficial to come together to figure out what we can do to create some sort of bill or piece of legislation that does that for navigators and have it covered by insurance so that everybody benefits. So.
And there is currently the CMS rule to reimburse principal illness navigation. It does need to come after a referral from a provider, so it might work within a system. For example, with an LA General, I don't know if there are any other representatives from here who can speak to that, but there is currently a reimbursement model.
I'm just curious, does anybody have any data on the cost benefit of patient navigation? We know it saves lives, right, improves outcomes, but what about the cost benefit? Any cost analysis associated with that?
I think there have been studies done on individual programs, but I think not recently and not here in California. And that might be a charge that we have over the next few years, is to focus on cost of specific programs and different models of programs, right? Comparative effectiveness across models.
And we can certainly help host a legislative briefing in Sacramento to talk about this and present some of the data.
I think there might be some data. I can try to
Okay.
dig some up for you too.
Okay.
And I know a couple people have talked about not spreading yourself too thin. How do we balance that against also creating efficiencies? We've been focusing really specifically on the cancer space, but for example, if there are any FQHC reps or those who work in the primary care setting who are trying to tackle multiple chronic diseases at a given time, is it more efficient to be navigating all of that, versus one specific disease or one specific funding mechanism to focus on this aspect of the cancer care continuum? Have people tested that or have thoughts about whether sort of a bundling approach versus a single disease approach might be more beneficial?
Well, don't community from a primary care perspective, wouldn't that be a role that the community health workers can play? I mean, we were co-sponsors of a piece of legislation that Dr. Akilah Weber, tried 2 times, the Social Determinants of Health Bill. And the first time around, it incorporated community health workers into the model of care for community health centers, but unfortunately, Governor Newsom did it, 2 times now. So I think the community health workers can play a role on the prevention and primary care side, and navigators can, maybe across all diseases, cancer being probably the most critical one, but maybe it could be a good demonstration project, right? Okay.
Okay.
Well,
Thank you so much for your insights, everyone.
Well, I just want to bring our symposia to a close by first thanking our sponsors, AstraZeneca, Genentech, the Ralph Lauren Center, and our new partners, Novartis, for joining this conversation. It's been a great day, and I want to, on behalf of the institutional leaders here at Norris, Dr. Karen Lerman, City of Hope, Dr. John Carpton, and UCLA, Mike Titel. We're really thrilled that you've spent the day with us, having some really important conversations. And I think what has been really, what I'm really grateful for is that this is our second sort of hosting this event here, and I've seen so many people come back to continue to engage in the dialogue. And I think we're now positioned to really move some of the initiatives forward with action. We'll be sending around an impact report so that you all can see what the conversations were. And then we can begin to I'm going to charge our group, our team, Trista, with sort of continuing the conversations to really move forward and advance some of the things that we've talked about here today. So thank you for attending. Despite the weather this morning, the sun's shining and bright outside now. So your commute should be better. You don't have to drive in the rain. I want to just end the discussion by really, again, thanking everyone and acknowledging my colleagues on the planning committee. Their names are listed here on the back of the program, but I'll just ask them to stand for just a moment because this really was a team effort that was a joy to work with. So everyone stand on the planning committee. I want to thank all of the speakers for sharing your expertise and insight around patient navigation, and we'll continue to. What was the quote, Rhonda? Turn up the heat. All right, cause some good trouble. Okay, thank you, everyone.